In today's webinar, we will have some exceptional speakers whom most of you will know, and I'm going to briefly comment on what this experience will consist of. First, Dr. Carmen Rubio, who is Embryo Research Director in Research and Development at Genomics Headquarters, Valencia, Spain, will give us a short introduction of how the embryo analysis is updated in a non-invasive way. When this is finished, we will have, in addition to Dr. Rubio, good friends and colleagues such as Dr. Denis Sakas, who is Scientific Director at Boston IVF in Boston, Massachusetts, US, Dr. Christine Allen, who is Director of IVF Operations at Elite IVF TM in New York, US, and Dr. Josu Franco, who is Laboratory and Scientific Director at Ruber International Hospital in Madrid, Spain. With them, we are going to focus on three main topics of interest: the embryo, the embryologist, and the clinician. Each of them will tell us what they think is appropriate in their respective topics according to their initial experience until today. And once each session are finished, we will go with the questions from you, from the audience. As I always do, we sincerely apologize for the number of questions that I'm likely not be able to ask to our lecturers. We will do our best to try to answer you in the next weeks. Of course, I also wanted to tell you that, as usual, once today's talk is over, in the next few days, you will receive a certificate of attendance and a brief survey of just 3 questions where we want to share your ideas, doubts, and concerns with us. And without further delay, on my part, Dr. Rubio, please, whenever you want, the floor is yours.
Thank you very much, and welcome to this webinar. Today is the time for the embryologists to share their experience using our Embrace test for non-invasive PGTA, and hopefully they will allow you to solve many of your doubts on how to incorporate this technology into your IVF laboratories. I'm going to give just a brief introduction about Embrace, our non-invasive PGTA approach, and how has been our journey from the clinical studies to the clinical application. We all know the importance of doing an FRD testing in preimplantation embryos to be able to improve our clinical outcomes in IVF and to decrease miscarriages. And now with NGS, we can also test the small fragments of embryonic DNA that are secreted by the embryos into the culture media. We have started with this research more than 5 years ago. You know from previous webinars that we have done several studies published in different journals to try to move from the proof of concept to identify the presence of cell-free DNA in the culture media. Then we did a pilot study that we published in Fertility and Sterility to understand the protocol that we should follow in the IVF laboratory, but also in the genetic lab, and the potential clinical impact. And then lately, we published in the American Journal of Obstetrics and Gynecology this multi-center prospective study in which we were expanding the protocol to different IVF laboratories to see how this works. So what we learned from these previous studies is that we can have this cell-free DNA in the culture drops, that the right moment to collect the medium is on day 6, is when we have a higher quantity of cell-free DNA because the blastocyst has a higher number of cells. And then in the next slide, we are going to give you an overview of the protocol that we recommend to implement in the IVF laboratory. And then you can have the opportunity to ask the experts after this presentation. We know that the main concern from the embryology point of view is to have contamination in the culture drop coming from different sources, from the cumulus or the granulosa cells that surround the oocytes, also external from the manipulation of the culture medium or in the IVF laboratory. So our efforts during the protocol are going to be in trying to minimize the impact of this contamination by preparing to work in right conditions, covering ourselves, covering the skin, the air, everything to try to avoid contamination from human cells, but also working, trying to avoid the contamination from the cumulus cells that surround the oocyte. So here you have an overview of the protocol for the IVF laboratories, in which it's very important to be able to remove these cumulus cells that surround the oocytes. Then we incorporate in the protocol some washes to minimize the carryover of these cells. In the later stages of development, we incorporate another series of special washes on day 4, and on day 4 we suggest to do a media change to move the embryos to a new dish with fresh media to be able to collect from day 4 to day 6 the DNA from this very particular period of time. So many of you already know the protocol. Many of you for sure are already users of our test. So please take the opportunity to share your experience with the expert embryologists that we have today. And regarding the clinical application of this test, as you know, we were doing these studies with more than 1,300 culture media, comparing the results with the trophectoden biopsies and the inner cell mass, and we were able to develop with our bioinformaticians team the probability of having a medium resulting in a euploid blastocyst. So we have developed this prioritization system that allocates its media in a particular euploidy score that represents the probability of a medium to correspond to a euploid blastocyst. So in this way, we can rank the embryos in a patient to which ones have the best chances to result in a viable pregnancy. And this is the idea of the test, to prioritize for transfer. Because of this test could be of benefits for many patients. All IVF patients can have really a benefit from this, and with the idea of decrease the number of transfers needed to achieve a healthy pregnancy, and with this to decrease the cost and the emotional burden. So we have improved our results once we started to work with clinics, and thanks to the involvement of the different IVF labs in all the world, now we have very good concordance rate of the culture medium with the trophectoden biopsies or full blastocysts. Because before starting to work with any lab, we start a validation process, training the lab and doing a small validation to see how the lab has incorporated the protocol and to be sure that we have high concordance rates and low contamination. So working with this validation result for many labs all around the world, when we are working with fresh blastocysts, our concordance rate are now 85.3%, and we can work with conventional incubators, but also with time-lapse incubators. The only requisite is to culture the embryos in individual drops. And if we have frozen blastocysts, we can also apply this test. If we have day 5 blastocysts, we can thaw and culture overnight with a very good concordance, as you can see here. And if you have day 6 frozen blastocysts, you can just culture for 8 hours to have close to 90% concordance rate. This is a work we published this year in the SRM meeting in collaboration with Dennis Saka's team and with Maria in Dubai. So these are data that for sure Dennis Sakas can comment later on. So these are the concordance rate we are playing now with 85% for fresh blastocysts and from 90 to 100% for frozen blastocysts. And we have done several cases so far. In the year that we have been starting with the clinical application, we have conducted more than 400 embrace cycles all around the world. We have been able to test more than 1,300 embryos, and we are collecting the clinical results from the different clinics. So far, they have reported us 50 ongoing pregnancy rates with more than 10 babies already born. And one important point for the further discussion is going to be main indication. So you will see that some laboratories are applying this in couples without indication, good prognosis patients, patients below 30 years of age or ovum donation. But other countries, other laboratories are applying this in patients with indications of high aneuploidy risk as advanced maternal age, recurrent implantation failure, recurrent implantation pregnancy loss, male factor, or mixed causes. So it depends on the country, of the circumstances, on embryo quality, that you can decide when to apply embrace cycles. We always say that embrace is a prioritization system. PGTA is still the gold standard for the diagnosis of aneuploidy. So there are different options according to the needs of your patients. but as you can see, the results can be very good. And just to finish this summary, we keep on doing research, and we are doing a prospective randomized controlled trial comparing the results by selecting the embryos with embrace in the intervention group compared to morphology. And this study is involving 10 centers all around the world. Hopefully, we will have results in about 1.5 years. So I just would like to finish thanking all the team involved in the development of this technology, working in the research, my team of PGTA, supported by Carlos Simon, our scientific director, then the clinical studies team and the medical studies team that many of you know because they are really doing a very nice follow-up of the cases, the bioinfo team, the embryologists of iGenomics, and all the iGenomics IVF laboratories around the world that are now incorporating this technology for the different countries. Thank you very much.
Thank you very much, Carmen, as always, for your brilliant introduction. And I guess it's time to invite our lecturers also to be here with us to start with the first main topic. So welcome, Dr. Denny Sakas. Denny, how are you?
How are you, Nasa? You sound very happy today.
As almost always. I would like to see also Dr. Josu Franco. Hello, Josu, how are you? I think you're muted, Josu.
Yes, thank you. Sorry. It's a pleasure to be here and try to share all our practice in the laboratory.
Thank you, Josu, also for being in here with us. And also Christine Allen, Dr. Christine Allen. How are you, Christine, today?
Very well. Thank you very much. It's an honor to be here with you guys. You're great.
Thank you very much. So I guess that we can start with the first main topic, the embryo. So Denny, whenever you want.
I think with, you know, as Carmen mentioned, finding the DNA in the culture media, I think that comes under the banner of the embryos. When we do IVF, they never cease to surprise us, I think. So just the surprise of finding DNA in the media is just, you know, it's something maybe I don't think many of us expected, but, you know, now I think you can't argue against that. We're getting information from this DNA. I think we don't yet quite understand why it's there. And there's a lot of research by many groups, including work that iGenomics are undergoing. So we're trying to understand that. But in terms of putting it into practice in the lab, you know, there are questions that people have, you know, about the change in protocol. So one of the things that's interesting is that you have to do, you know, several washes. That's not strange to us in the lab. I think that's something we do anyway. The question of transferring, you know, at day 4 to day 6, I think is one of the big questions that we have. But, you know, if you go back 5-6 years, we were using sequential media and changing it. So, you know, to change media during the cycle in the lab, many labs still do it. Many labs still use sequential media. Many labs, even with the one-step media, will still change media. So changing media during the IVF cycle, you know, when you're doing blastocyst culture is, again, not something strange to us. And I don't think people should fear it in any way. The other two main aspects of the change in protocol is, firstly, culturing in smaller droplets. This is something, you know, many labs have been doing for many years, culturing in small droplets and actually culturing the embryos individually. One thing that's interesting about the day 4, day 6 protocol, in effect, you could actually group culture until day 4 if that's what your lab does, and then move them to day 4 to 6 individually. And we've been doing this for many years in biopsy, just routine biopsy, and we know that it doesn't hurt the embryo. In labs I've worked in, we've always done individual culture because we've always tried to get the information from that embryo. So again, this is things that are not strange to the lab. The small culture media, we've been using small culture drops for doing media assessment for many years. So even going down to 4 microliters in some instances, and we've never seen any adverse effect by culturing in smaller droplets. The biggest change probably for many clinics is that you have to keep to this rigid day 4 to day 6. So you actually have to freeze your embryos at day 6. And a lot of people have a lot of concerns about that. And we even had some concerns about it. And so we actually, when we were doing the studies with iGenomics, as part of one of the multi-center trial, we went back and actually looked at our PGT data when using the non-invasive protocol and only freezing embryos at day 6 or some minor ones at day 7 versus doing PGT normally and having day 5 frozen embryos, day 6 frozen embryos, and even day 7. And actually we saw absolutely no difference in the pregnancy rates when we did the day 6 freezing only, or vitrification, sorry. And what was interesting is that we definitely saw no difference. We had a slightly improved euploidy rate, which was not expected, not significant, and we're actually going through all this data at the moment to see if there are any differences. And we actually had some ease in actually performing the biopsy, because obviously we were doing the concordance study. So in relation to having a fear of, not freezing embryos on day 5, it did two things. It actually allowed us a day off during that cycle, if you want. So and it absolutely did not cause any harm or adverse effect on the patient's cycle. So I think switching to the non-invasive protocol has many benefits to it, actually, and I think maybe we'll talk about the time a bit later. But in terms of the protocol that the lab utilizes, I see no fear in actually introducing the actual protocol itself in terms of non-invasive PGT. I'll let the others comment also, Christine and Yosu.
Thank you very much, Danny, and the really interesting data, because this is the main fears that people have at the lab when they are going to start a new protocol, right? So, Christine, could you talk to us a little bit about it?
Yes, sure. Firstly, I have to say that speaking in between Dr. Sakas and Dr. Franco is absolutely intimidating. We're talking about embryos. These guys have the best data in the world about what's going on with the embryos in here. But since I'm here in the middle of them, I have to say I have all those fears. So everybody that is in there watching this and saying, oh, he has the best, one of the best labs in the United States. He has the best embryologist. Of course, he doesn't have any fear. Everything works so well for Dr. Sakas in there. I'm scared every time I'm starting in a new clinic, because I don't know if the embryologist is going to take too much time to make those droplets, because you have to be really well trained to do that. You don't have if the entire facility is going to work well. My experience is with smaller clinics, and I set it up for places that have a little bit of difficulty, and that usually there's a play along with embryologists that are not that proficient with that. So every time that I'm trying to implement something new that is high technology, if it's vitrification in the past or if it's embrace now, I'm always terrified. In the clinics that I worked, I started doing the work myself, and I was, of course, very worried about the 10 microliter drops. So I did a little bit longer validation to make sure that I have data enough clinic by clinic to go to the physician and say, here's your data. And your data is stating that there's no difference between the small droplets and the change of media in day 4 and what you had before. So we're going to talk about that a little bit better when we talk about the embryologist in here and my study design. That was long, but still. We fix that problem with very straightforward conversation with the physicians and the embryologists and making them see their own data when we do the study validation. I see a lot of people complaining that Embrace has such a lengthy and sometimes time-consuming validation. That's absolutely necessary. You cannot go with a technology that is different and then new and little tweaks in there go against what people are used to without doing a serious validation taking it seriously and paying attention to the details. Detail-wise in the protocol, I personally had a little bit of difficulty with the precise 10 microliters to put it in there, and collecting. I can share more what happened to us and how we tweak things. But every time that I tried to help some clinic and where I implemented myself, we were very successful tweaking those little details and getting the best possible pregnancy rates. I think Carmen just said that we have 50 OPRs right now. And when I saw that, I was like, oh, okay, so we have a lot of pregnancies, which means it's reassuring that we're doing the right things, even if we have very tiny, precise details, tweaks that we have to do from clinic to clinic. So we're all good with that. And I'm not gonna delay Dr. Franco's opinion here on the embryo because he has a lot more to talk about this than me. If anyone have any questions about the embryos, please feel free to send it in writing, and I'm gonna try to address that as soon as I can.
Thank you, Christine. It's really important to know also the idea and the thoughts about smaller clinics, because when you have a new development, a new tool or anything, we would like to have it as universal. You know, we don't want that it only works in a certain clinic or here or there. We would like to be able to use it everywhere. So thank you very much for your information. And Josu, please, can you go ahead with the part of the embryo?
Yes, and Denny and Christine, they told us more or less all the aspects, but I would like to put a different aspect in our experience, especially with the kind of incubators and the way the people around the world, they are working. Because normally now introducing the time-lapse system, and depend what kind of time-lapse system you are using, the protocol can be a little different, or the people are afraid for grow embryos until day 6. Normally when you speak with different embryologists around the world, oh my God, it's gonna happen something if I grow the embryos until day 6, especially in day 5, I see a very good embryo is like expanded. And when we start with this technique, before, of course, in our thought, we think, oh my God, let's see what happened with the embryos in day 6. And now we don't have any afraid because we see very good blastocysts with more cells in the trophantoderm. We perform the biopsy regularly, and now I am thinking to do all the biopsies in day 6, not in day 5 and day 6, because I have confidence with kind of embryos. And it's very important also to understand that the people can be afraid to see the embryos hatched, to be fully hatched. And the percentage the embryos, if you go to blastocyst state fully hatched, is not high. We have like 6% of the embryos go directly to blastocyst stage, especially in day 6. Then the percentage is low, and then this kind of data try to help us and to push everything to day 6, especially not only with the non-invasive, also with the invasive for the future. Then it's very important, depend what kind of time lapse you are going to have. Also, no problem if you don't have adapted the specific dishes, because then you can change the embryos day 4 until day 6, and a special low concentration oxygen in an incubator. And if you don't see in day 5, the embryo is not going to have any problem. We have one specific incubator, and at the moment the dishes, they are not made for the this kind of procedures, no invasive, and we are doing in the same way. And day 4 we change the embryo, and then we put the embryo until day 6 in low concentration oxygen, and we have very good results, and we don't have any afraid. And especially try to get out this afraid like to blastocysts in day 6, because they need so us also tell us that the pregnancy and the ongoing pregnancy is the same from blastocysts from day 6 to day 5. Then this is our experience at the moment, and with all the comments that Christine and Denny told us before.
Thank you very much, Josu. Carmen, would you like to close the topic, please?
Sure. I will try to summarize the 3 opinions together. So thank you for sharing your experience. I think that the main conclusion is that by these small modifications in the IVF protocol, you can have good clinical results. And these small modifications are related to the size of the drop. If we are using a benchtop incubator, that should be between 10 to 15. If we are in labs incubator, 25 microliters is okay. So it works in both situations. And I think that what is very, very clear is that it works in different IVF lab, different culture mediums. And as you mentioned, Christine, we can work together to identify how to adapt the protocol to different labs, big and smaller, and we can be flexible, understanding the way you work. So we are adapting more the protocol to the needs of each different labs. And the basic thing, as we mentioned, is to remove cumulus cells to avoid contamination and to extend the culture to day 6. So as you mentioned, day 6 was the most difficult thing for the embryologists to accept, but you can see from the experience of our team that you have good results also with vitrification and transfer of embryos after this situation. So we think that we have 3 centers sharing with you the opinion, and that you can see how this can be a safe protocol to apply to obtain the cell-free DNA.
Thank you very much, Carmen, to summarize. So then I guess that we can move it, because I would like to remind all the audience that they can start sending. Actually, we have already 5 or 6 questions, but they can start sending the questions, and we will do the Q&A session at the end of all the 3 different topics. So we can move for the next one. We are going to talk now about the embryologists, the second big topic. And in this part, we are going to talk about the impact that the adoption of the Embrace has had in the laboratories, how you have adapted your daily routine, if it costs more or less time than doing an embryo biopsy, and so on. So in this case, Christine, I would like that you please start with your opinion, with your experience.
Thank you. Here in this part is where the 2 most frequent questions that I get live. So the first question is, what about the time? This is going to take so much time to do those drops, and then I have to pass the drop. Forget about it. No, whatever you're thinking right now, audience, no. Once you start using the technology and you get used to it, it's not going to be more time than biopsy. You're going to be just as proficient and as good, and that's going to happen during validation. So once the machine is well oiled, again, you don't have to be the best IVF clinic in your country. Embrace is still going to bump your pregnancy rates, and you're going to be fine, and you're not going to need more expenses or more time in the lab for that. Second question that I get very frequently is, how did you do your study design? Because my study design was a little bit longer than the others, and I like to call it humane. I always start from the principle that we're all adults here, the doctors, the patients, and the embryologists, and we deserve full disclosure of information of everything that is happening at all times. So I always start with an informed consent for the patients. If they're going to participate of the validation, they're going to know what's happening. We're going to split the samples that the patients produce, the fertilized eggs that grew until day 4, in 2 groups. One group is going to stay exactly how it was before, and one group is going to go into Embrace protocol. At the end of the validation, we're going to have some numbers in there to share with the physicians and with the patients, and we're going to provide an in-house statistics or a pre-statistics, a percentage, whatever we got during that validation, that shows that everything is okay. And in that setting, Embrace is not being detrimental in any way for those embryos of that patient. So we work with the physicians and the patients involved as a team to make this work during the validation process. And after validation, I think we try to not leave any doubt that this is beneficial, and we're going to use it for priority transfer for the patients. Another question that we just discussed a little bit was day 6. Day 7, forget it. Nobody's going to convince me. I'm going to be with the audience that is in there watching us and just doing, yeah, I'm with you. Day 6, I do look at embryos on day 5 at night. Oh, but that's so annoying. Forget it. You're an embryologist. It's your job. I look at them at the end of day 5, and if one of them is hatching, then I already have a plan set with the physician, with the medical director of the practice. We can talk about that later by email or however we decide to. I understand all the data that backs the decision of transferring fully hatched blastocysts. I still don't feel that the theory supports that data, and I'm still uncomfortable with it. So fully hatched blastocysts, either because they suffered a biopsy or because they stayed in there too long, I'm still the devil's advocate for that one. So we do have a bit of a prevention protocol to avoid that happens with our embryos. And that's not only with Embrace. If regular transfers, day to day, start getting late and later and later, and suddenly I have an embryo in there that's half hatched, doesn't matter if it's PGTA by biopsy, no biopsy, whatever, they're gonna see me mad. I just don't wanna take the risk. And these were, I think, the main questions that I have gotten so far in the embryology lab part of embracing.
Thank you very much, Christine. Yosu, do you want to go ahead with this part?
Okay, the impact of our laboratory was not complicated because we have routinely making the biopsy like every day and so many biopsies, and then we try to focus and try to introduce a new technique and where is the best thing to do it. Then we have to have confidence, and also it's very important to adapt it. The different steps has to be like more quiet in each step, and especially before to introduce the technique with the patients, like Christine said, like the validation. When the validation start to see that the data are more or less the same and you have a very good concordance, the confidence is better, not only for embryologists, also for the physician part. And then you can start with more confidence. It's the same like I told you before, not only when you have this concordance, also when you start to see that the culture, the embryos, doesn't matter is time lapse or is an incubator mink with low concentration, don't affect the embryo. You have very good quality, the number of the blastocysts it's okay. And also I get out there afraid to have expanded fully hatching because it's not high percentage, it's a few, and then with the results we have also with this kind of embryos are the same. Only it's very important, the people in every embrace, they have to do it. Always they have to focus to be the concentrated. Everything has to be very clean, like when you are doing PGT, but a little high level, because if everything can change or can have any variable. And always this focus on in the protocol, we focus a lot in these steps, and also the embryologists are working with me every day do biopsy, but it's very important to focus to clean everything very, very strictly, more than you are doing PGT, because you are going to take out the variable. But if you do in this way and you can see after the validation that the results are okay, the quality of the blastocysts and everything is going well, then the confidence you have in this technique start to grow more and more, and you can put a light regularly in your lab.
Thank you, Yosu. Denny?
So we've only used the protocol under an IRB or a clinical testing, if you want, with in the different trials we've been doing. We have numerous staff trained to do the protocol, and juniors and senior staff that have not had really any issues adopting the protocol. In terms of saving time, I personally, I think it's no argument that non-invasive PGT is going to save you time. People may argue, but I personally don't see how the non-invasive is going to take you more time than doing a biopsy. depending on your biopsy or your invasive biopsy procedure, you know, it will change quite a bit. Our own invasive biopsy procedure involved actually changing droplets at day 3 once we laser hatched them or introduced a laser or a hole in the zona. So for us, we were changing embryos into a new droplets anyway for some of these patients. So this procedure didn't really, you know, didn't add anything else to us in terms of changing. As I said, the time is, I think it, you know, there isn't an argument about that non-invasive will save you time. It's a lower bar in technology. So if you have more junior embryologists, you're not going to train them in doing a technique that's as difficult as biopsy. So in the long run, I would argue that it's actually going to be more beneficial to you doing the non-invasive PGT rather than you know, invasive PGT. The final point, and I didn't mention this in the first part, and I don't know if anyone will ask about it, but the question is, can you do conventional insemination, conventional IVF when you're doing non-invasive PGT? And, you know, I'm well aware of the results that, you know, I think 66% or nearly 70% of IVF cycles around the world are ICSI now. That's a completely different argument why that number is so, and I'm well aware that many clinics do 100% ICSI. We're not like that. We do about 50-50. So one of the first things that we did when iGenomics approached us to do the trial was actually, we said we do quite a lot of conventional insemination. So part of our results with the validation of non-invasive PGT actually involve validating it with conventional insemination, and maybe not surprisingly, using the same but we had exactly the same concordance, if I remember, with the non-invasive PGT using conventional insemination. So
I guess that we are losing Danny. Danny, are you there?
I think my audio may have failed a little bit during the talk. I'm not sure how much of that you got.
No, we lost you only about 10 seconds, the last 10 seconds or 15 seconds maybe.
Okay, the message was that non-invasive PGT does work with conventional insemination and not just ICSI.
Thank you very much, Danny. Pretty clear as always. Carmen, would you like to close the topic, please?
Yes, delighted. So I think it's very clear from the 3 points of view that validation is a key thing to get confidence from the embryologists, from the lab side, to be familiar with the protocol and to realize that it's not so difficult. And as you mentioned, should be less time consuming than regular PGTA and can be adopted by junior embryologists, not only by senior embryologists, because the protocol is simple. So this is one important thing. And as you mentioned, Christine, this also helps clinicians to get comfortable with the incorporation of this technology. That I think this is very, very important. So yeah, validation is the key, and I'm glad to see that you all agree with this. You mentioned, Christine, that you are a little worried about fully hatched blastocysts, and this is okay. Different labs has different experience. So I think that talking with different labs, we can understand how to work, if it is okay in those cases in which you have very fast development, to try to incorporate like checkpoints to identify what to do in these cases, but should not be a big issue. That this is something that can be solved. And Denny mentioned one very important aspect, that is the IVF. So we learned with Denny at the very beginning that with IVF we can have very good results. So you don't need to go through ICSI to have nice data, because the thing is that the regular protocol that we have for whole genome amplification, the sperm is not amplifying. So we are not scared about the sperm. We are scared about the cumulus cells, and from the embryologist side about the cells from the human. So it's very important to be completely covered, and I'm going to emphasize this part because just things as not covering the arms can make an impact. So it is important just to cover everything and maybe to incorporate, as in the drawing, the surgical gown to cover the arms with gloves, because this is one of the issues, that if we have contamination in the aliquots of medium or in the tips or in the hood that we are working, this is going to be incorporated in the analysis of the media. As we say, when we are working with in regular IVF, we are very scared about fungi, about bacterial. With Embrace, we are scared about contamination with human samples. So this is very important, and it's easy to avoid. So this is what I wanted also to incorporate in the discussion. So thank you.
Thank you very much, Carmen. So again, for all of you that are with us today, just you can still send in your questions, and we will make at the very end. But now we are going to move to the last but not least big topic of the session of today, and it's about the clinician. What are the main indications, clinical results, how to present the technique to patients, the patient feedback on the results. And this time I would like to start with you, Yosu. Please, can you go ahead with and share your experience?
Okay, when we introduced the Embrace in our department, the first thing we did was a meeting with the clinician, especially after the validation, and to tell them that we have a confidence in the technique because the concordance between the PGD and the non-invasive works very well. And then try to establish what is the cutoff or in what kind of patients is necessary or we think that is necessary to introduce this technique. Here in our hospital, we perform the invasive PGD after 38 years, but always we are thinking that if you are less than this age or in ectonation, for example, you don't need to do it because you are going to have more euploid embryos. But we know that the oocyte also, when they are young, between 30–35%, you have an euploid in the oocyte, and we start to introduce this technique in this kind of patients, normally in the good prognosis patients. And we start in less than 38 years and also in ectonation to figure out and to check if we can increase the ongoing pregnancy rate, especially in this point. And we saw very good results because in patients then less than 38 years, we have an ongoing pregnancy 66% now with Embrace, and before without Embrace we have like 55. At the moment we have 10% increasing ongoing pregnancy rate, and happened the same in ectonation. Then with this kind of results, also the physicians start to have a lot of confidence because they see that you don't need only what is the pregnancy rate. The most important thing is what is your ongoing pregnancy rate. And when they start to speak with the patients, especially they are in front of the patients, we show what are the results, our results, and also the statistics around the world in Europe and in America when it's not with genetic. But when we implemented a genetic technique and also it's not invasive and it's not affecting the embryo, because normally the patients, they are worried if they are going to affect the embryo or it's going to do something wrong if you touch the embryo, and you show the data, the patients receive the information very well, and they see also what is the confidence we have in the technique and how you can speak and how it's going to increase or try to increase the pregnancy rate. Because when you have the opportunity to increase the cutoff from the patients around the world and try to increase in this kind of patients, why not to do it and try to reduce the time of half a pregnancy in one only transfer and not to wait the accumulative pregnancy to have the same result. For this reason, we start in this kind of patients, and the information received the patients, how they adapted when they receive the information is very, very well. Then we have very good result with this. At the moment, we are thinking in this kind of patients, but probably we are going to start probably the next year increase a little more, 1 year more, 39. Let's see what happens, because we have different patients with this age and the results are okay also with the non-invasive. And in the future, the genetic technology is improvement very fast. And then when the concordance is going to be higher than we have now, probably in the future the non-invasive could be established for more people or more in general patients. This is our experience.
Thank you very much, Joshua, for sharing. Denny, please, you can go ahead and explain a little bit about this part.
So we don't have as much clinical experience as the other two do, but I think the main point of interest is the way that the embryos are then actually sorted, and I think Nasser, you're probably the best to talk about ranking maybe, and I think the most important thing is actually how you interpret the results. So I don't want to go into sort of the whole discussion about mosaicism and how the results are interpreted, but I think that one of the interesting parts is that, one, that you're getting the picture from the DNA secreted by the whole embryo and not looking at a part of the embryo, and that's always something we believe that may actually be just as informative. And secondly is the type of results that maybe non-invasive PGT will eventually give us, and that's in actually the ranking of embryos. So for a patient that obviously has euploid embryos, they will be ranked higher than the ones that may indicate some sort of anomaly and then maybe some more drastic anomaly. But even with invasive PGT now, we've seen that we don't, I think, have a technique that is black and white anymore, that it's a technique that actually is giving us some black or white, but it's giving us a lot of grey. And I think the data's, you really can't argue against the data now coming out that indicates that this area of greyness may actually be greater than what we ever thought. So I think clinically, the way we adopt the non-invasive PGT will be very important in terms of how a lot of clinics choose to adopt it and allowing us to understand which embryos we will transfer and what order we transfer them.
Thank you very much, Denny, again. So Christine, your time. I think you are muted, Christine. Thank you.
So I'm right on target with what Yosu stated. We are about 12% pregnancy rate, and I think that's huge for egg donors, young patients that just want to get done with it. I fully agree with everything he said. I'm just not going to repeat it, of course. I think biopsy has never been benign, and I was not comfortable offering biopsy PGTA to patients that are either egg donors or young. It's just counterintuitive. And with Embrace, I'm fully confident and comfortable to offer that. Priority of transfer, that's the key. As Danny was saying, our gray area with PGTA, it was predicted to be much grayer than white or black, and now it's showing to be that much grayer. And with using a ranking of prioritizing what to transfer, everybody is showing to be much more comfortable with that. Patients prefer that. Physicians have a relief from that kind of report. And in the lab, we're much, much, much less prone to making a mistake. So I think those 3 points give us enough information to conclude that, yes, this is the future. I'm just agreeing with Dr. Sakas. As vitrification was, and a lot of people in here will remember how many lab directors and embryologists said, I'm never going to vitrify. This is never going to take off. And look at us now. Here we are again in the same situation. People are insisting in the biopsies. The future is going to catch up with you. So I am still a big supporter, even working with smaller clinics in settings that can be a little bit more challenging and more time consuming. But I do think we're living the future before a lot of other people out there. And I'm happy to participate in any capacity. Thank you for the opportunity.
Thank you to you, Christine, please, for sharing your experience. And this is what we are looking for, to have the whole experience about it. So Carmen, if you want to close this last topic, please.
Yeah, sure. This is going to be shorter summary, but I think that you agree that this can help to increase ongoing pregnancy rates, and most of the experience of Joshua and Christine has been in good prognosis patients, and even with low risk of aneuploidy, you can increase by 10 percentage points ongoing pregnancy rates. So this is nice to see. And also, Joshua mentioned the decrease in the time to pregnancy, because if we select the best embryo for transfer in the first attempt, this is going to be a good thing. And then he was mentioning the philosophy of ranking and how this is coming also to the PGTA field, in which we have many great results. So it's not so easy what to do with mosaic embryos or with segmental aneuploidies with PGTA. So we know that we have also a range of different results with PGTA that can allow to prioritize the embryos in PGTA. So with Embrace, we have started in this way. So prioritization and ranking could be a good tool for the future to avoid to discard embryos and to make easier decisions. And I like the comment of Christine that the patients give you very good feedback. So this is really, really, really important, because we always think, should we incorporate patients in this kind of user meetings? So maybe next meeting we can incorporate patients, because this is very important. We were always asking to the clinicians, how difficult is for you to explain the report and the Embrace test and the ranking thing. So if you say that the patients understand perfectly, I think that just by giving them the right information before the treatment will help for sure to have good results. And as you mentioned, maybe it's releasing not to decide to discard embryos. So I'm going to decide first which one I transfer, and then I don't need to think that the other ones are going to be discarded. So it makes sense that it's a good thing for patients. So thank you very much for all the comments. Thank you.
So thank you, Carmen, and thank you all. So I would like to be here the whole day, just listening to all of you, but I do know that you're really busy. So let's move into the Q&A session, because we already have a lot of questions. And I started the introduction apologizing to all of the audience, because I'm sure that we are not going to achieve to be able to answer or to ask to our lecturers all the questions that we have, but we are going to try to do as max. And if we cannot make all of them, we will try to do it in the few next weeks. So there are some questions that probably you already talked about it, but if people is doing right now, so maybe they will need like not further explanation, but do it focusing in there, and also some of the questions that are asking directly for your own experience, because for instance, this one, I think that they are thinking in the study that Denny performed, because the question is, do you perform cryopreservation of all blastocysts now on day 6?
No. So we were only doing that during the trial. So we haven't gone completely over to that. But I think as once we start adopting more non-invasive PGT, and we're actually part of a randomized trial now. We're just about to start with iGenomics on non-invasive PGT. We will actually be doing both the controls and the non-invasive PGT cases on day 6 and some on day 7, obviously. So we haven't gone completely over to day 6 freezing, because we're still doing all the majority of our cases with invasive PGT. So that's still requiring us to freeze as per usual.
Thank you, Danny. I'm going to make some questions that you both, 3 or 4 of you, can answer. So there's one of them that is I would like to know about the total denudation. How do you achieve this requirement without feeling you are causing some damage to those oocytes that are more difficult to denude? Also, dose exhaustive denudation was described to have a detrimental effects. Carmen, I don't know if you want to comment first on this total denudation, and then Danny, Joshua, and Christine can talk with us about what they do in their labs, right?
Okay. Yeah, first thing is to comment that you don't need to be aggressive during denudation. You just need to do your regular denudation. We recommend not to place all the oocytes in the same hyaluronidase drop, not to have so many cumulus cells together. This is something that you can split the oocytes in different drops. And you don't need to be very aggressive. You just need to be aware that you have to remove as many cells as possible. And in regular cases, you can remove almost all of them without being aggressive. Then through the different washes, you can limit the number of cells that you move from one drop to the other. And we always say, if you have oocytes from POC patients or kind of immature oocytes in which it's very difficult to remove all the cumulus cells, don't stress the oocyte more than necessary. Just wait, and on day 4, usually during these special washes, the cells are looser and you can remove usually without any problem. So you don't need to be stressed or to stress the oocyte during ovum denudation, because you have a second opportunity on day 4. More than denudation, that is very important too, is to try not to carry over floating cells in the drop. So that's why the serial washes are very important, not to have floating cells, not only the ones attached to the zona, but to try to avoid to take the floating cells.
Thank you, Carmen. I don't know if Danny, Josu, or Christine, you would like to comment anything on this part, or then we can move on the next one.
Normally, like Carmen said, that it's very important in case all the cells are around the zona pellucida with the washings in the day 4. But before, after the retrieval, normally we cut you have so many granular cells around the oocyte, and we cut before to do the hyaluronidase the granular cells with a needle, and then you can reduce more cells at the beginning, and when you are gonna do the hyaluronidase, you put this oocyte, normally remove all the granular cells around the zona pellucida. We don't have any problem, because before, after the retrieval, we cut granular cells, and we keep less granular cells from the beginning.
I'm just gonna share my trick, because the cutting technique works really well for some labs, but I see an increase of zona problems in a lot of little labs, in labs with a lot of juniors with the cutting. What I always say is, please don't be stingy. You have hyaluronidase, and the word never comes out. Enough. Just don't try to save it. Don't make me 50 microliter drops to denudate 20 eggs. Just don't. Use enough. Big drops and big wash drops. That always helps a lot. It's just a little trick, because I have to go through a lot of clinics and a lot of different embryologies and settings. So I think for me, working with a variety of settings, it works more consistently.
Thank you, Christine.
It's the same for us. So we do the same as Josu mentioned. We actually trim the cumulus cells before conventional and ICSI. And also remember, once the eggs are fertilized, the zona hardens. So with Carmen, exactly what she said, the actual cumulus cells come off easier once you do the day 3, day 4 washings. So that actually facilitates the actual the leaving of the cumulus cells, if you want. So we don't do anything more aggressive, less aggressive than normal with non-invasive.
Okay, so I guess there's clear that there's no more aggressive denudation, but the regular denudation. And thank you also for the tip and tricks that in this special session, I think that people is what is looking for, that what the experts are doing in order that this work perfectly. So I can see like 3 different questions regarding the hatchet embryos. and also a comment that could be kind of solution of some of them. So let me make the questions, let me make the comment, and then let's comment about this. So first question is there any change in the routine process in case of cryopreservation of fully hatched blastocysts? How to avoid full hatchet, and how is their approach when the embryo is full hatched in the morning or day 6? There's a comment after that questions that say if there is no need to count hours, only days, maybe it would be an option to perform IVF ICSI at late hours, evening time. So there will be less chances that some of the blastocysts, about 6%, as you mentioned, will totally hatch on day 6. So we already have a comment, like a trick from the audience. But would you like to comment about if there's any change in the routine process in case of cryopreservation of fully hatched blastocysts, or how to avoid it? Or how is your approach when an embryo is full hatched in the morning of day 6?
Normally, when we found a fully hatching, we collapse the embryo before to do the vitrification, because before we have this experience, the results are good. When we found the percentage I told you before is a small percentage, we collapse the embryo and we keep in the equilibrium medium like 7 minutes, and then after thaw, the expansion and everything is okay, and the results at the moment we didn't found any difference comparing with the embryos are inside of the zona pellucida. Always we collapse the embryo.
So similar to Yosu, I think the fear of hatched and hatching blastocysts comes from the old slow freezing days, because it really didn't work well. A lot of things didn't work well with slow freezing, but hatched blastocysts didn't like slow freezing at all. So vitrifications, in many ways have saved us a lot of anguish for freezing, but I think a lot of the fear of hatched and hatching blastocysts comes from, the old data we used to have with slow freezing. So we really don't see much of a difference when they're hatched, hatching, not hatched. We do some collapsing, but it really doesn't seem to be as big a problem as it used to be.
Thank you, Denny.
I agree. Yeah, the hatching does help. In my experience, we do have reduced ongoing pregnancy from fully hatched transfers overall, for cryo, not cryo. So it is a concern I have. I never had a fully hatched embrace blastocyst transferred. They're usually hatched, but not fully hatched.
Thank you all.
We have experience at the moment. We transfer in 7 patients embryos like fully hatched. From 7 transfer, 6 was pregnant, and the ongoing pregnancy is going very well. And normally we select not from inside of zona pellucida, but in case you don't have it, we are transferring, and we don't see any difference in the pregnancy rate at the moment.
Thank you very much, Josu, for sharing. There's also a question that, although I understand that PTSR is a gold standard, do you have any experience on efficiency of non-invasive identification of structural rearrangements in the culture medium? I guess this is for you, Carmen.
Okay, we have few experience. We are not offering this because we don't think that we are ready for offering this as a diagnostic test for translocations, but we are testing this for sure. In the validations with several centers, they have incorporated cases from carriers of translocations, and we have been able to identify small segments above 6 megabases, more or less the same resolution as we have with trophectoden biopsy. So in terms of the accuracy of the test and the resolution with NGS, is going to be very similar to a trophectoden biopsy. The only issue is that we need to be completely sure that there is no contamination, because the risk of a misdiagnosis in a carrier of a translocation is severe, as well as in a monogenic disease. It's not the same to incorporate the technique as an haploid testing to improve clinical outcomes compared to the cases in which we have an inherited problem. But the accuracy and the resolution is just very similar.
Perfect, Carmen, thank you very much. So there is also another question that I'm asking, based on experience from all 3 groups, which was the main indication where Embrace was opted over invasive PGTA? I cannot, if there's any. Because, yeah. Which was the main indication where Embrace was opted over invasive PGTA. So, I mean, Josu, you said that you were performing PGTA for patients over 38 years old, and if there's...
Yeah, we have the cutoff in patients more than 38 years old with the PGTA, the invasive, and now we are doing the non-invasive in less than 38 and in egg donation program at the moment.
Oh, but there's no, so far, PGTA indication performing with Embrace from your groups, I mean. Because Carmen showed because Carmen showed at one slide that even though we're still saying that for PGTA indication, patients with PGTA indication, we would like to go for this. We have some of the clinics already performing with other indications, right, Carmen?
Yes, and we have to understand the situation because we have patients that they are of advanced maternal age, for example, or recurrent implantation failure, that they don't want to touch the embryos, they don't want to do the biopsies. So this can be an option for these patients and also for these countries in which, or these clinics in which the biopsy is not available. So we think there are many different scenarios per country, per clinic, and per patient. Some patients, even they have a high aneuploidy risk, they don't want to touch the embryos. And we have received the feedback from several clinicians and patients that if they have a low number of oocytes and the blastocyst quality is so, they opt for Embrace. So I think we have different feedbacks from different clinics.
Okay, there's a one talking about also the media that Denny was mentioning at the beginning, and it's for those of us using sequence media that make a refresh of the media on day 3, we move the refreshment for a day 4.
No, normally in our practice, we keep the embryo from day 0 after the ICSI until day 4 because we are using the single stem medium. And then in day 4, the day before, we make the dishes for the Embrace. And in day 4, the embryos, they are continuous growing and in the stage is necessary to have. Then we move to the Embrace. But at the moment, we don't refresh the embryo in day 3 because there are several publications that if you remove or not remove, the results are the same. And if we are in our mind, then it's not necessary to touch the embryo or don't remove the embryo again, and the results are the same. To remove the day 3 until day 4, and in day 4 again to remove, you are doing several variables. Then we don't remove the embryo or refresh in day 3. No.
I think if I understood the question a little bit differently, for whoever is changing on day 3 right now, yes, stop changing on day 3 and change on day 4. That would be my answer.
Yeah, I understood the same that if you're using sequential media, can you change day 3 versus day 4? This you would probably, to be comfortable with your cells, you would probably have to test that for your cells, but I wouldn't believe that it would be deleterious to change, early day 4.
I can just add to this that many IVF clinics are working with sequential media and they are delaying the media change early day 4. Mm-hmm.
Perfect, thank you very much. For those that are doing already transfers based on different indications of PGTA, which indication group has the best success rate with Embrace? So I don't know if you have enough results like in egg donation versus young patients or anything like this that you can say which one is the best one so far?
Okay, guys, I think it's an unfair question. Which group age has the best success rate? Well, I think I would qualify this as which group has the highest increase comparing Embrace with PGTA conventional or embrace with nothing. I think I'll go with that. That said,
Okay.
other than very poor prognosis, not related to genetics of the parents, I would say they equally grow. I have in my experience.
If I can add something, we have been collecting data from different IVF centers and splitting the results below 38 and above 38. And if we don't go above 43, so just thinking that the advanced maternal age is something between 13, 39, 43, the ongoing pregnancy rate per transfer is very similar to the young ones.
Perfect, thank you. They're asking about the droplet. Why a droplet for a regular dish should be between 10 to 15 microliters, and for time-lapse it can be more?
Okay, I guess this is for me, and this is a very good question. So with time-lapse, we have learned that if we culture with 25 microliters and then we aspirate about 18, 20, this is going to work nicely. And the trick is to collect the medium from the very bottom of the well. So our hypothesis is that in time-lapse, the embryos are set at the bottom most of the time, and the cell-free DNA should be around this lower part of the well. So the very important thing with time-lapse is to have a tip or a capillary that you can place inside the well until the very bottom, and to be sure that you are aspirating the medium from the very bottom. So in this case, you have the DNA concentrated in this area and it's working nicely. When we are with a microdrop, we have a big surface and we have the embryo in a big surface. And when you are aspirating the medium, you should avoid to aspirate oil. So at the end, there is going to be some medium that is going to be a stick to the bottom. So if you prepare a very big drop, you are going to have a very big surface, and it's going to be a lot of medium at the bottom where the embryo is stick to the dish. This is one of the potential explanation that we can give with this. But based in our learning of the results with time-lapse, we now feel comfortable saying that if you don't like to work with 10 microliter drops, 15 microliter drops will be okay. But try not to go bigger because of this. It's because the surface in contact with the dish and the medium that you can retrieve by a regular aspiration.
Thank you, Carmen. We have a lot of questions related to the hatchet situation of the embryos, but I think that we already covered that part. So really, really nice to have you in here. Carmen, I think that this one is also for you, that they are talking about it. It's more likely DNA in culture media comes mainly for chromosomally abnormal cells going through apoptosis, leading towards false positive results.
Okay, well, maybe we can comment this together. We have indirect evidences saying that should not be from apoptosis or from aneuploid cells undergoing self-correction, because we have very good concordance rates. And I have shown you the slide of the collaboration with Benny and with Orchid of the frozen blastocysts. You can have concordance rates close to 100%. If this DNA would come from a apoptotic cell, we will never have this very high concordance rate. And we have also a very nice collaboration with Denis Sakas and with Nilo Fran in Brazil by doing the biopsy of the inner cell mass. And we have the data. Also, it was the poster prize in the SRM, in which the concordance rate with the inner cell mass is also very high. So we have some indirect evidences that this DNA is not coming in the majority of the cases from apoptotic cells, or at least the classic, under the classic apoptotic mechanism. We are working very nicely in collaboration with Nicolas Placha Lab and with Denis Sakas Labs to do live imaging and to understand, and hopefully in the future we will have some explanations, but we are almost sure that it's not through a common classical apoptotic pathway. Denny, I don't know if you want to add.
I can only comment, like it's it's intriguing where this DNA comes from. It's 100% it's there, because otherwise, you know, you wouldn't get these concordance rates. We don't know why it's there. Is it, you know, is the embryo using it as a cell signaling device? We really don't know. We are doing experiments to understand it. We know, I think we can believe quite strongly that it's not junk DNA. It's not, you know, rubbish that the embryo is just spitting out for no reason at all from aneuploid cells, from some apoptosis as we know it. So there is some meaning to this DNA that it's been put out. It's just, we don't know yet. You know, sometimes we have an analytic result that we use clinically that we don't quite understand. And one of the classic is prostate-specific antigen. We've used this for many years, and many people still don't know what actually it signifies. But we know it's a marker for prostate cancer or an indicator. So there are things we have, you know, the knowledge that we have that we don't quite understand always the intricacies of it. And I think the DNA in the media comes under that banner.
Thank you very much again. So we do have a lot of questions still in here, but I would like to finish on time, I promise to you. So please, if you can make a brief summary about all the three main topics that we were talking during this great session, it will be our pleasure. So you cannot imagine how many people is writing, not questions, but saying thank you to all of you for your tips, tricks, for your experience. So thank you very much from the audience. So please, Christine, if you can make your last statement about the session, please.
Sure. I think Embrace is making our lives so much easier, so much patients, so much more confident than they were with the biopsies. And physicians, in my experiences, are overall happier introducing Embrace to a patient that is coming to the clinic than answering or not answering all the questions that come with the biopsies. So to me, it's just what is coming next in the future, and we're already participating at this. So thank you very much for the opportunity. I always learn so much listening to you guys that these webinars are very productive for me too. Thank you.
Thank you to you, Christine, for sharing your experience. Yosu, please.
My resume could be like, it's easier to introduce this technique. You don't have to be afraid like to keep the embryo until day 6 and it's gonna find like fully hatching blastocysts, because at the moment they are working very well, and also the morphology of the blastocysts until day 6, all your blastocysts you are gonna find are okay. The perception for the patients are very good, and also not only the laboratory, also the physicians, they are gonna have more confidence, and specifically when you have like the option to know that the embryo has like priority to be like euploid, you can get out different variables for the future in case you don't have any pregnancy, or the physician have another option, so has to study more the patients. And it's going to be the future, I think, I am completely sure, that especially with the genetic technology is growing very fast, and I think the concordance is going to be higher in the future, and then it's going to be the future technique.
Thank you, Yosu. Denny, please.
Thank you again, you know, for everybody joining. I think one of the things that might be interesting, and this drives my embryologists crazy when I tell them, is that there are a lot of embryos we just can't biopsy because they're just off the right, quality. So what may be interesting is that non-invasive PGT may allow patients maybe one more embryo that we could biopsy that may be euploid, even though it might be, under Gardner a 3cc or something. So I think it'll be interesting in the future, as many clinics adopt non-invasive PGT, and I hope they can, to see how actually it changes maybe the way we do the analysis. And hopefully, you know, that's why we're all here. We'll give patients a better chance maybe to achieve that live birth that they, you know, they're really striving for. So I would hope that in the future it gives patients actually a more robust chance of achieving a pregnancy while using some sort of analysis.
Thank you very much, Danny. Carmen?
Well, I would just like to thank Christine, Joshua, and Danny for being so transparent and so open, sharing your experience with all the people attending. I would like to thank also all the embracers or the labs that has started to adopt the technology, because I think that during this journey that we started some years ago together, we all have learned a lot. So I cannot imagine how this would have been if without the interaction that we have with the IVF lab. So I think this has been a fantastic journey because of this. We have been talking with many embryologists all around the world. You are now talking among you. So I think this is also fantastic. We are learning so much, or we are learning that we don't know too much about embryo biology. This is what we are learning. So many things to try to unravel and to discover. So I think this is very exciting, just from the scientific point of view, but also from the clinical point of view. And as you mentioned, you three, I think that it's very nice to start with a proper validation and little by little to get confidence in your lab. So this is the opportunity to start little by little. I think this is a very reasonable thing. Thank you.
So I guess that we are at the end of the session. Thank you very much again to all of you, Danny, Josu, Christine, of course, Carmen, mother of dragons, no, mother of Embrace, and of course to all the audience that is still in here with us, still making questions. We will try to reply to you again in a few weeks. And thank you again to all, and I hope to see you soon. Not online, but on site. Thank you. Have a great day, all. Bye-bye.
Thank you. Bye.
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 Thank you.
Thank you.